everyone. Welcome to today's Global Brand Rounds. My name is Aisha, and I'll be your host for today. Before we start, I'd like to go over a few things. So this presentation will be recorded and uploaded to our YouTube channel. On Zoom, if you would like subtitles, there's a feature called closed captioning during the presentation. And also, please create a Figure 1 account if you would like to gain CME credit. If you have any questions about this, please let me know. I've provided all relevant links in the chat. And I'm going to go ahead and hand it over to Dr. Pekia to present our speaker today.
Thank you, Aisha, and welcome everyone. So glad to be back here in first edition for 2025 of Global Grand Rounds, many of division and supported by Global Offsite Care, non-governmental organization out of California, and partners with Rotary International to support telemedicine for the underserved globally. And I'm so happy to welcome Dr. Otto David today, who has spoken to us before on various topics, and I think represents the essence of our collaboration with partners around the world and relationships that start with providing telemedicine and evolve into collaboration and bettering our knowledge about the challenges that face many of our patients in various parts of the world. Dr. Otto David holds a Bachelor's of Medicine and Surgery from Kabbalah University. He's currently completing a Master's of Medicine in Orthopedic Surgery from Kampala International University at the Ishaka campus. He is also a Rotaractor who is doing a fellowship with a Rotaract Club of KIU. I believe that's the Kampala International University, Ishaka, and Rotaract Club of Global Alumni. Today, Dr. Otto will examine the case of a polytrauma patient, detailing the essential approach to acute management, including comprehensive assessment, diagnostic evaluation, and treatment strategies. With that, welcome Dr. Otto, and looking forward to your presentation today.
Thank you so much, Dr. Pekia, for the great introduction. To all those who have logged in from wherever you have logged in from across the globe, good morning for those in the Pacific, that's in California and the like, and those in Africa, specifically East Africa, it's evening, so good evening. So today's presentation is going to capitalize on a polytrauma, but I know most people have been wondering who is a polytraumatized patient and who is a multiply injured patient. So today I'm going to clarify the difference between the two and also similarities between the two terminologies, but so to speak, the two terms can be used more or less interchangeably. I'm going to begin with a case presentation, and then we dwell more into the discussion later on. Just a small declaration: there was no any conflict of interest while preparing this presentation. There was no any financial gain, and this is purely for educational purposes. And all names and identity of the patient has been concealed for confidentiality purposes. Yes, so the case is of a 29-year-old male who was single, a motorcycle rider, presented to our accident and emergency with pain and inability to use the right lower limb following a road traffic accident 3 hours prior to admission. He was fairly well till 3 hours prior to admission when he lost control while riding his motorcycle. After dropping a customer, he tried to overtake a trailer, and yet on the opposite side, there was another smaller vehicle coming. So in an effort to avoid a head-on collision, he lost control and ran into a trench. The bike threw him up and landed with his knees directly on the ground. He suddenly developed severe pain, worse with movement, relieved with rest, and was associated with inability to walk or stand. However, he did not lose consciousness. He was then picked up by volunteers and rushed to KIU Teaching Hospital for emergency. His past medical history, there was nothing significant. There was no NS, chronic illnesses, HIV. It was HIV serostatus. There was no history of past surgicals or any blood transfusion. Family social history, he stays alone, separated with a wife, and currently working as a motorcycle rider. He's a non-smoker, however, an occasional alcohol drinker. He is a second born in a family of two. Both parents passed on. He has two children, and both staying with his ex-wife. So on examination, at the point of arrival, he was fully alert, conscious, not in respiratory distress, but was in severe pain, with bruises on the face. Clothes were all soiled with blood. There was mild conjunctival pallor with moist mucous membrane. There was no central or peripheral cyanosis. The blood pressure was 110 out of 75, and the pulse rate was 110 beats per minute. His SpO2 was saturating at 98, and the temperature was normal. So, on local examination, the limb was laterally rotated with the deformity of the left lower limb with the deep lacerated degloving wound on the medial aspect of the leg. It was actively bleeding with impacted soil and the foreign body. The thigh was swollen with obvious deformity noted mid-thigh with contusion of the medial thigh, as you can see in the picture. The femoral popliteal pulse were all present and they were rapid. The tibialis anterior pulse could not be well appreciated on the affected limb. The foot was cold on touch and was pale. As you can see in the picture here, there was a slight active movement of the hip joint, but there was limited active and passive movement of the knee and ankle joints. Investigation we did at that time, we took off blood for CBC, we did a complete blood count, we did the grouping and cross matching, RCT was negative, hepatitis B and C was done, and an X-ray was done as below. So this was the hip X-ray that we did, and there was a complete cervical hip fracture, Garden classification type 2. Then this was the femur, as you note, a mid-shaft fracture of the femur, and this was there was a short oblique fracture of the mid-shaft of the tibia fibula of its lateral limb. So our management, we resuscitated the patient in A&E with the normal saline, analgesia. We gave pethidine and tramadol. We immediately rushed the patient to theater where thorough debridement was done, and external fixation was done on the tibia and the femur. We also transfused the patient 2 units of blood intra and postoperatively, and the cannulated screw were used to fix the cervical neck fracture after 2 weeks. So that was not done immediately. We did it after 2 weeks. Intravenous antibiotics. The patient was initiated on intravenous antibiotics, specifically metronidazole and ciprofloxacin, for about 2 weeks. And he was later discharged after 1 month. So this picture was an intra-C-arm, that's a fluoroscope. As you can see, this is how we were able to fix the hip. That was after 2 weeks. This was under C-arm guided percutaneous cannulated hip screw was used to fix the cervical neck. This was basically done after 2 weeks, as I told you earlier on. So this was the intraoperative pictures that were taken to fix the limb, as you can see. So that is a short case that we had, and it is on that I'm going to base my discussion for today. Who is a polytrauma patient, and who is a multiply injured patient? I remember when I was sending out my invitation to friends and colleagues to join in the discussion, many were correcting me that no, it is supposed to be multiple injured patient. Actually, for record purposes, to correct you, the actual medical terminology is a multiply injured patient. Multiply injured patient is the standard and acceptable terminology to refer to a patient, as I will explain in my subsequent presentation. So who is a polytraumatized patient? A polytrauma patient refers to a patient with 2 or more organ systems, and each injury on its own being sufficient to warrant hospital admission or death if not treated. So I gave an example here is a case of a traumatic brain injury and a splenic laceration in the same patient. So you can have a patient who has injury on the same organ system. For example, you can have a brain injury and a splenic injury. You realize The brain injury is in the CNS and the splenic injury in the what? Is in the GI. And then a multiply injured patient, on the other hand, is one who has two or more injuries to the same organ system. For instance, a perforated bowel injury and a liver laceration. So this is one of the things that, okay, I was reading different literatures, different researches, but most researchers were talking about polytrauma, and yet they're actually referring to a multiply injured patient. Because someone who has the polytrauma usually will have different systems. There are usually two or more systems. For example, a patient can have a musculoskeletal, multiple fractures with a head injury, then disqualified to be a polytraumatized patient. However, someone can also have multiple fractures, but with no any systems, without any other system affected. This patient qualifies to be a multiply injured patient. So for this case, the case we have talked about is actually a multiply injured patient. But I used the polytrauma in my introduction because I wanted to bring that issue and that differences quite clearly well. To look at, so I'm going to concentrate more into the definition of a polytrauma patient because it is the one that, if you look at it, they say you have one injury is sufficient enough because admission, or it is a serious admission, or it can even result into death. Like I mentioned, the definition of a polytrauma has also been evolving over time. I remember the first definition was initiated in 1960s. But later on, there was another new definition. So there was a recent definition known as the Berlin definition. This was formulated in 2014 by a panel of experts from across the globe. So the Berlin definition defines polytrauma as a life-threatening injury involving at least two body regions, and each with an estimated injury score of greater than 3, as well as at least one positive physiological parameter. By this physiological parameter, we mean that it can, in elderly, those are patients above 70 years, those with low systolic blood pressure, for example. So you can have a patient who come in with the polytrauma, or with a patient who come in with maybe multiple fractures, but also has low blood pressure, will have low GS, we also have coagulopathy or acidosis. This is a patient who will definitely qualify to go into a polytraumatized patient. And according to injury severity score is basically used also, on the other hand, to categorize your patient. As you can see here, ISS, that means injury severity score of greater than 17. That means patient is very severe. As you can see in this presentation, in this slide, that injury severity score is, we basically use it to categorize our patients into different severity categories. One, it can be a minor injury, can be moderate, can be severe injury, or can be critically injured patient, basing on their ISS score. So we say 1 to 8 is basically minor injury, and then 9 to 15 is moderate, and then 16 to 24 is a seriously injured patient. And you can use this. So if the patient has head injury and head and neck, the injury is within the head and neck with the cerebral contusion, then this qualifies to go under 3. You score it as 3, and then you go up to get the injury severity score. You go on squaring your scores. So 3 when you square, you get 9. 4 when you square, you get 16, and then you add up, and then you severity score. So this severity score also guides you on the outcome, to predict the outcome of that, of your intervention. Because most patients within who score 50, 75, the outcome is usually poor. If you're in a low resource setup, with the poor manpower, with poor critical staff, you can easily lose such a patient. These are patients who, in most cases of the time, will benefit from ICU. Epidemiologically, there was a study that was done by Mathers and CD in 2009, and they realized that most of the polytrauma mortality is decreasing world over, especially in the Western world. And this was attributed to more advanced vehicles with the better safety measures, They said this was contributing to, they said in developing countries, whereas in developing countries, it's the 8th leading cause of deaths worldwide. The same study also says 1 in 8 male in the, whereas in females, it's 1 in 15 cases of polytraumatized patient will die. Another study was done in Ghana, that was in 2014. They reported the prevalence rate of polytrauma to be at a 3.4, which was higher than the one that was done in Mali. In Mali study, they showed that it was 1.6 prevalence. There was something unique in the one that was done in Ghana, that 66% of the males, of people who are polytraumatized, were males. And this can be basically explained to the fact that males tend to be more active, they tend to be more on the road, the nature of the job. Most of them are border riders, most of them are truck drivers. So this can actually explain the prevalence. Why is it that majority, 56% are males? The mean age that was found at 32%, 32.9%. The mean age was 32, and this was ranging from 22 to 40%. Called Davis. So brain injury was the most common associated injury, with about 81% of patients with polytrauma will always have an injury. So what is unique with this is that most patients with polytrauma will have head injury. 81% of them will have head injury as an associated injury. As this study was done by ANWA in 2024. So they realized that out of all the patients that were received in that hospital within a given period of time with polytrauma, 81% of them had head injury as an associated injury. So what is the recent developing assessment of patient with polytrauma? As you understand that the ATLS protocol still remains, and this emphasizes an evaluation of rapid and the prioritized evaluation of patients in a matter sufficient enough to identify the life-threatening injuries. As you assess your patient in, for example, in accident and emergency, bear in mind that ATLS protocol still remains the gold standard. However, when you look at the investigation, I was trying to read the different papers, what could be the latest recommendation as reported by different researchers. We realize that most trauma centers are now advocating, or most researchers are advocating for what we call the whole body CT scan. But the CT scan is an investigation where you are basically doing a head-to-toe CT scan of a patient. However, there was a controversy as to the safety and also the cost implication. So most researchers were saying, if cost is not a problem, then it will be beneficial to do a whole body CT scan, because they say it identifies rapidly the subtle injuries that could be missed out, as it was reported in a study done by Uber and others. They did a study where they were comparing whole body CT scan versus a non-whole body CT scan. They realized that those with whom they did the whole body CT scan, there was a survival rate of about 25%. And so they concluded that it is better to do a whole body CT scan, despite the fact that they are increasing the patient to significant radiation. There was also a risk of cancer, and another study that was done to evaluate whether it is true a whole body CT scan was significant. And they came to realize that for every 10 MSV of radiation exposure, the risk of cancer increases by, actually for every 10 radiation, the risk of cancer increases by 1 in 10,000 people. This was study done by Costello in 2013. So it comes back to the physician or the surgeon in the emergency surgeon in accident and emergency to determine whether your patient indeed needs a whole body CT scan or not, because the more you subject this patient to a whole body CT scan, you're increasing their likelihood of getting a cancer. They also recommend, there was also another recent development in the diagnosis, where they said in the diagnosis of C-spine, National Emergency X-ray Radiography Utilization Study and the Canadian Spine, they ruled that the rule evaluated clinical criteria, and this was still controversial, where they were trying to assess whether it is true, whether other than doing, okay, the study was basically evaluating the role of clinically evaluating a patient for C-spine, involvement of a C-spine fracture, without having to do it radiologically. And this, they realized that clinically it is quite difficult to ascertain whether it is indeed important, whether clinical evaluation will give you better prediction, whether clinical evaluation is a better predictor. So they realized that actually the best way would be to do it using radiologically, and they recommended a plain radiograph. So alert and awake patients without neurological or distracting injuries who have no neck pain or tenderness, no active range of motion, can have their sequelae cleared without the need for cervical spine image. So this was a conclusion that was done by Jennifer and others in 2012. They were trying to debate the recommendation by the Nexus and the Canadian C-spine rule, where they say every patient who comes to A&E you must rule out the C-spine basing on radiographically. And for her, Jennifer says no, we can as well depend on clinical evaluation. So this was still controversial. As those who are interested, you can still read more and more papers as more researches are still being done whether clinical evaluation has a role in ruling out C-spine involvement. Then there was also another study or a recent development basically on the blunt cerebrovascular injury imaging to rule out intravascular bleeding. It was quite difficult because others were saying that when you do so many radiological imaging, you're exposing this patient to more and more radiation. That's when the other study of the whole body comes in. When you do a whole body CT scan, you're increasing the likelihood of identifying blunt cerebrovascular injury. So these were all studies that were trying to evaluate the role of radiology in assessment of patients. How would you manage a patient, a polytraumatized patient, especially in a low resource setup or high resource, high advanced hospitals? The American College of Surgeons Committee on Trauma devised a systematic approach, and which is commonly known as the Trauma Life Advanced, the Advanced Trauma Life Support Protocol in 2008. And this has now become the gold standard in the assessment, management, and evaluation of patient of any polytraumatized patient. And where your priority is on airway maintenance with the cervical spine protection in both at the trauma scene or at the accident and emergency. Then you also need to you evaluate the breathing and ventilation and the saturation with hemorrhagic control. So you need to control your hemorrhage. And then the other thing was the disability and neurological status assessment, basically the GCS and also the glucose estimation. And then exposure and environmental management, where you completely undress the patient and prevent hypo. So how would you approach the patient? There was a report that said that when you look at patients, a polytraumatized patient, majority of patients will die in the first hour. And those who die in the first hour, what is the cause? Most of these patients will die because of hemorrhage or brain injuries. So within the first 1 hour, you need to evaluate the patient, the GCS, whether the patient's GCS is deteriorating, whether the patient is bleeding, because failure to manage the bleeding and the brain injury at that time, you're most likely to lose the patient in the first 1 hour. Those who die later on, several hours later on, most of them will die because of airway problems, because of breathing problems, or because of circulatory problems. Maybe it can be, for example, the circulatory problems can be cardiac tamponade, pneumothorax, and also airway blockage, maybe asphyxia or something also, that such a patient will die later on after 1 hour or several days later on. And then those who die 1 week later or 1 week afterward, most of them will die because of sepsis or multiple organ failure. So you can see this can guide you on how best to approach your patient in accident and emergency, and also prevent mortality with the later on complications from multiple organ failure and sepsis. Assume you have managed your patient by the ATLS trauma protocol, which I've not really gone into the details. I'm assuming you have maintained the airway, the breathing, the saturation, you managed all the breathing, you managed the disabilities. If the GCS is low, you have put the patient on oxygen. If your neurologically, you have assessed the patient and you have exposed the patient, examined fully, head to toe, then you need now to manage the complications that will lead into how are you going to manage hemorrhagic shock and how are you going to prevent hemorrhagic shock? One, you need to put large bore IV line, normal saline, blood transfusion if need be. You need to be, in case there's alteration in blood pressure or pulses, you need to monitor for capillary refill, urinary output, arterial pH, the bases, if there's base excesses, okay? Those are all you need to do. A retrospective study was done in about 1,590 patients with traumatic brain injury, and they found that anemic patients transfused had a higher mortality than those who were not transfused. So this study really, it was so controversial because they recommended that. So their recommendation in that study was that patients with that patients HB or the hematocrit should be maintained at 30%, and the hemoglobin level should be maintained at 10 milligram per deciliter. And they said this to be optimal. So I tried to read in details to find out why, but the study really could not come out. So those who are interested, you can go and read. I've referenced it. It was done by Salim and others. It was quite an interesting study that I read. I thought patients with low HB should be transfused, but instead they recommended that your HB should not go above 10 for reasons that was not clear. So maybe that was a gray area that could warrant further research. How do you categorization of patients? So after initial assessment and stabilization, patient can be categorized into stable with no major signs of physiological disturbance. So assume you've managed your shock very well and you've managed everything, those acute causes of death, then you need to categorize your patient into stable, borderline, or unstable, because this categorization is going to tell you, is going to guide you further for definitive management. For stable patients, you may not do much. You just keep them around the ward you admit them on ward basically for observation. And then for borderline patients. So the borderline patients, these are patients that can easily deteriorate or can easily tip over into the unstable group. Or if you continue with resuscitation, they can actually get into stable. So these are patients that you really have to keep a keen eye and monitor very well because they can easily deteriorate within a blink of an eye. Then we have others, we categorize them as unstable. These are basically patients with no responses on initial resuscitation. And these are patients you need to do damage control orthopedics, as I will highlight more on what we call damage control orthopedics. Then we also have extremist patients. These are very close to death. In fact, the only life-saving procedures are done. For example, they have uncontrolled bleeding. So patient in extremis, the likelihood of losing them is close to 80%. And these are patients you most likely admit in ICU. Then there is something which I also found, which I thought is important, the triad of death. The triad of death is one which is going to kill the patients in the unstable and the extremist group. And we said the patient with acidemia, hypothermia, and coagulopathy. These are the three triads. If you have one of them, you are most likely to lose your patients if you don't intervene in time. Look at damage control, as our discussion is more into polytrauma. So now this is now going to relate it back to the case that we discussed. What is damage control orthopedic? Damage control orthopedic, it is a concept that was developed with the aim of stabilizing patients who are in severe multiple organ or whose injury severity score is very high. close to 50. So these are patients that you wouldn't remember. Orthopedic surgeries, most of them are very long. You can have a surgery for over 3-4 hours. So most of these patients, this is not a patient you want to subject to intramedullary nailing, not a patient you want to subject into those aggressive operations. The patient you want to rush into theater within 40 minutes is out of table. And they cannot withstand very long surgery. So is a patient, your aim is to stabilize the fracture. Stabilizing the fracture you're basically aiming at 3 goals. The first goal is to reduce pain, because when the fracture ends are stable, then the patient will have reduced pain. 2, it's also to minimize fat embolism. Remember, the more, so these are patients. So I was talking about your goals of damage control. The other one is also to promote early mobilization of the patient, because when you stabilize the fracture as early as possible, you're actually also decreasing on the hemorrhages, you're decreasing on. So the likelihood of this patient getting back to walking or to their pre-injury state is higher. This damage control orthopedic is basically done in the borderline and unstable patients. You may not do it in stable patients. For stable patient, you go straight away for definitive management, maybe fixation, okay? This is also done to prevent further damage, but not definitely fix fractures after trauma, as I illustrated earlier. It also stress, what we call the second hit. For purposes of clarity, we have the first hit and second hit. The first hit is basically the trauma as a result of the accident. And then the second hit is the trauma as a result of your surgical intervention. So you want to minimize the second hit, the trauma that is resulting from your surgical intervention. That's why you want to do as the minimum soft tissue involvement or surgery as much as possible. And basically, we use external fixators in damage control is the most preferred method for fixating or stabilizing your fractures. So how am I relating it to the case that I presented earlier? So that patient came in and he had the multiple fractures. He had the tibia, he had the neck femur, he also had the femur midshaft, and also had the tibia fibula of the same limb. It was a ipsilateral limb. So realized this was a patient that with also a serious degloving leg injury. So we realized this patient was actually very unstable. He had lost quite significant amount of blood. So this is a patient we could not fix all the fractures. So what we did, we went and debrided. After debridement, we put external fixators, and we then aimed to achieve these 3 goals above. So we did that within a very short time. So we did not actually fix the femur, and because the femur was closed and also the neck was also closed. So we only basically stabilized the tibia, which was open. So after about a week, we went back and we fixed the femur. And then also later on, after 2 weeks, we went back and fixed the femur neck. So you can see how we did what we call serial operations, because so what we did was actually damage control orthopedics. In definitive treatment, you can see management of other injuries, especially intra-abdominal head injuries. These take precedence, especially in extremist patients. So what are some of the definitive treatment? Definitive treatment in orthopedic can be permanent fixation, for example, intramedullary nailing, as you can see in the picture in this X-ray above. It can also be plating and screw, as you can see here. This was for pelvis, and this was for. So these are some of the permanent or definitive fixation method. As for our case, we went in and we did intramedullary nailing of the femur with the cannulated screw of the hip, because this patient was very young. What are some of the complications that could arise from polytrauma? One is the compartment syndrome, hemorrhagic shock, pulmonary embolism, fat embolism, multiple organ dysfunction, and the pneumonias. These are part of the complication that can arise as in case patient is polytraumatized. And remember also, polytrauma patients, or we can have they can have the head injury, chest injuries, we can have limb, so all those are traumas. But remember, priority is given to those injuries that you think may result into death of the patient, like, for example, hemorrhages and also head injuries. Okay, so in conclusion, treatment of multiply injured patient or polytraumatized patient need individualized approach. One size doesn't fit all. You need to treat patients as they are and how they present. However, the principles remain the same. ATLS principles remain the same: airway, breathing, saturation, and others. Sequence of treatment is from tibia, femur, pelvis, and the upper extremities. As you can see in this case, we started with the fixating we fixed the tibia because it was an open fracture. Then later on, we went and fixed the femur, and later on, we went in for the pelvis. The pelvis was treated, was fixed later. Staged fracture management for extremist patient is recommended, and if not possible, then you do damage control. Orthopedic is applied. Unstable patients, stopping bleeding and stabilization of the tibia and femur and pelvis is prioritized. Those were the references. For those who are interested in reading articles, you can check them out and you read them out. This marks the end of my presentation. Questions are welcome.
Thank you, Dr. Otto. That is much appreciated, and a topic that is of interest to really anyone who is involved in frontline medicine and also organizing health system services to prepare for taking care of people that have unfortunate injuries like this. I'll go ahead and kindle some question and answer time here, and I have two questions. One is, what was the eventual outcome for this patient? How did it turn out for him? I think first thing that for many of the uninitiated here would be, what ended up happening to that limb, his lower limb, especially since he presented with a cold foot and what appeared to be a near traumatic amputation. Did the limb survive, and did he actually have a reasonably decent outcome?
Oh, yes. Thank you so much for that question. Yes. Actually, that limb survived very well because we were able to intervene very fast. We were able to intervene immediately. So we took the patient theater where we did debridement. It is true, it was almost a traumatic amputation, but when we reached the theater, after the debridement, the pulses started returning, especially the pedal pulse started returning. And indeed, the patient, as I speak now, is much better. So the external fixators were moved. He is now on partial weight bearing. So yeah, the limb was saved.
Amazing. Great job. Mm-hmm. I know where to go if anything like that happens to me or my family, right? I should give you a call and your team. That's absolutely wonderful. Second question, and then we'll open it up to the group. For complex cases like this one, is there a role for advanced telemedicine? And an example would be if a case like this occurs in a rural area that has limited resources, no CAT scanners, so things like whole body CT, et cetera, or advanced imaging, or the availability of advanced orthopedic care is not available. Is there a role for live or asynchronous telemedicine to facilitate expert opinion and assistance to, including teledirected surgical management of an injury like this? Is that something that is being used yet in your domain or others that you've seen to, long story short, to be able to help out those unfortunate individuals and or providers who have less than optimal resources to take care of complex injuries like this?
Yes, it's an interesting question. Yes, it is true. In such a scenario, there's room for telemedicine because now, like in my setup here, in my training, in my residency, we use a lot of telemedicine because Uganda is not privileged with having very many orthopedic surgeons. So we actually, like such a case, this is a case that you immediately inform your supervisor, you send a picture, an X-ray, and then Some will tell you, okay, take the patient theater, do debridement, put external fixators, I will see the patient later. Some will tell you, okay, do ABCD. So that's already becomes telemedicine. But also, there's also a situation where such a patient is taken to a center where they don't have X-rays, they don't have CT scans, but maybe the doctor there, from nowhere, you see him calling you and telling you, I have such a patient, ABCD, what can I do? Because they know the moment they refer such a patient, actually can die second to bleeding. So you usually, we have, I think on a number of occasions, I've discussed such cases with the colleagues online. I've told them what you do is, if you think you can't manage, wash with the maybe saline, pack with the gauze, apply splints, and then refer. And at least they end up bringing a patient who is not as worse off as the injury occurred. So yeah, we have tried to do that. I don't know if that answers the question, but it is most of the time such cases, they tend to go direct to a higher level centers.
In your area, I'm curious, so what are the logistics of that? How would you transport a person from a remote area in potentially hours away from your major medical center for where you practice? And is it done by air? Is it done by vehicle? And if so, are there personnel that have some expertise out there in some of these under-resourced environments that can competently get that person to you?
Yes, I would. This question, I'm going to request one of my mentors. I don't know if he still remembers me, Dr. Daniel Odulusi. Is online. I don't know whether you can hear. Doctor, you can answer this question. How do you transport patient? Dr. Odulusi is a police surgeon. That's why I'm interested in him answering this question in particular. Doctor, how do you transport patient to higher center?
Thank you, but all the patients are transported by the available vehicle, by road always, to the nearest center. If an ambulance is available, and good, but usually the most or nearest available vehicle will deliver this patient to hospital.
Thank you. All right. Any other questions from our attendees today? Feel free to ask anything you want of Dr. Otto.
Dr. Otto, I had one question. During your slide where you were speaking about the complications of polytrauma, you listed compartment syndrome. I don't know what that is exactly. Can you explain that for me?
Okay, yes. Compartment syndrome is one of our nightmares. In orthopedic, we have two deadly complications arising from both our elective surgeries and also emergency, especially in traumatology. There are two. One of them is compartment syndrome. The other is infection. Yes, that one is self-explanatory. But compartment syndrome is it is a syndrome because it is where you have the intramuscular compartment pressures increasing beyond the arterial blood supply to that compartment. How can I illustrate this? You have a situation where, for example, the leg has anterior compartment, the lateral compartment, and the medial compartment. So these have what we call fascia, the compartments that are fascialized, and each compartment has its own blood supply, arterial drainage, and so in case there is a increased pressure, this pressure could result from inflammation, could result from blockage of venous return, could also be anything, could be from inflammatory situation. So the pressures within the compartment will increase, that will cut off arterial supply to that compartment. And as a result, this will affect the viability of the limb. So this usually have what we call a positive effect, positive feedback effect, that when the pressures increase, it even worsen until you get a total arterial blood supply, and you result into loss of that limb. So it's one of the major complication that you wouldn't want to have. And for purposes of this presentation, so in case you have a patient who comes with there's no pulse, the limb is cold, it is swollen with blisters, with excessive pain that is beyond, then there is a likelihood of a patient having compartment syndrome, and such a patient, you have to do immediate fasciotomy. And that's the only way you can save that limb. Hope for those who are not doctors, I've tried to use the simplified terms to explain that. Yes, thank you.
Maybe her question, if I got very well, was what is the correlation between polytrauma and compartment syndrome?
Okay, polytrauma. And you said polytrauma and compartment syndrome, if I get you right. Please come again with your question.
Thank you. If I got her question was the correlation between polytrauma and compartment syndrome, since it was listed as one of its complications.
Oh, okay. The correlation is simple. Usually when you have a fracture, for example, this patient had a fracture of, he had ipsilateral tibia. He also had tibia and femur, mid-shaft femur at the same time. So in case you have a fracture within the compartment, you're risking increased blood hemorrhage within that compartment. Now, the bleeding within a compartment will increase the interfascial pressures. So, and as a result, you're going to compromise of the venous return in the mechanism that I mentioned earlier on. So, this patient had femur, at the same time had tibia. So there was already increased pressure within the thigh. At the same time, there was increased pressure within the leg. So that alone can increase the likelihood. But we intervened early because we were able to fix the patient, to fix the fractures intraoperatively. So we did not actually get compartment syndrome. Is that clear?
Maybe if I can, yes, if I can maybe try it also to supplement. In polytrauma, you have the concept of systemic inflammatory response syndrome that affects all vascular beds throughout your body, causing exudation of fluids. And this can occur in the limbs, affecting the limb vasculature, and that can predispose you to compartment syndrome. Also, of course, in polytrauma, there is a high likelihood of being hemodynamically unstable with hypotension. And we know in compartment syndrome, basically, you have compartment pressures being higher than the perfusion pressures of different limbs. So if you are hypotensive, even the slightest compartment pressure can predispose you, can increase the risk of compartment syndrome compared to someone who has more systolic mean arterial pressure. That's what I could maybe supplement.
Yes, thank you so much, Doctor, for that supplementation. Yes, I hand you back to Aisha.
Any last minute questions?
And all right, thank you so much. Mine is not a question per se, but some kind of scenarios that do happen in our country, Uganda, especially when it comes to polytrauma. We are so much burdened with motorcycle accidents here in Uganda, and the services for orthopedics are quite limited and maybe to a few areas. And in most cases, you find most of the facilities along the highway, and we are being faced with high numbers of polytrauma patients, but it becomes a big challenge when it comes to transportation and the issue of equipping the frontline health workers with ATLS protocols to be able to handle these polytrauma patients. And I think this presentation is really timely to show us how to handle the polytrauma patient and in terms of stabilization and the categorization that Otto has said. If all members could be equipped with this, I think we could be saving quite a big number of polytrauma patients. But we find most of these patients, we lose them because of the first 1 hour of arresting hemorrhage and really trying to see how we handle them at the site or at the scene or at the first encounter, wherever they reach. But because of this shortage of the orthopedic team, I think we are a bit underprivileged. But I think if we can be having some of these presentations and discussions, and we invite all primary providers to be part of this, there can be a lot of change, a lot of learning that would help us really try to reduce mortality among these polytrauma patients. Otherwise, mine was a thank you, and let's keep up with this and keep learning more. Thank you.
Thank you for your comments, Dr. Herbert. And I couldn't agree more about the importance of this, and also to thank Dr. Otto for his presentation, a great example of helping us at Global Offsite Care meet our mission, which is building connectivity bridges for telemedicine that also foster collaboration, as we're doing here, and ultimately to the benefit of our patients, one patient at a time. Thank you again, Dr. Otto. Also, some other thank yous to Aisha. Did a great job helping us through and facilitating, and also she looks like she turned on the summarizer. So we'll have a little AI summary that I think she'll be posting in addition to our YouTube video of this, also to Figure 1, where additional collaboration and dialogue can happen. Also, of course, to Global Offsite Care itself, its benefactors, its donors, including local and also international Rotary groups. And also, I'd like to recognize Western University of Health Sciences, College of Osteopathic Medicine, my employer, that helps facilitate freeing myself and our team up for supporting this effort. With that, I wish you all a healthy and prosperous new year, and hope to see you next month and beyond later in 2025 at our monthly sessions. With that, I'll hand it back to Aisha.
Thank you so much, everyone. Thank you, Dr. Otto, for your presentation. Some last reminders. So I put the YouTube link, the Figure 1 link, and our website link on the chat, in the chat below. Our next Global Ground Round is scheduled for February 12th. And thank you all very much. Have a great rest of your day. Thank you.